Hello everyone. Today we are going to discuss antileprotic drugs. It comes under 6th semester Pharmacology GTU syllabus and myself Dinesh Dangar. While coming to the antileprotic agents, these are the agents which are used to treat bacterial infection, and the specific bacteria are Mycobacterium leprae and the disease, that is leprosy. Here we can see the signs of leprosy. Here, in the cases of leprosy, we can see specific skin lesions in round sac. Generally, it will be present on superior surface of the skin. Leprosy is caused by Mycobacterium leprae, and it has been considered incurable since ages and bears a major social stigma, a kind of mental condition where people used to thought that or think that the disease cannot be cured, and that is the basic reason why they used to hate, or a kind of intransparency can be seen with the patients suffering from leprosy. Due to the availability of effective antileprotic drugs, now it is entirely curable, but certain deformities or defects that is already incurred may not be reversed, and those skin lesions can be seen even after the treatment. Classification. While coming to the classification for antileprotic agents, what we have, that is four major categories. First, that is sulfone, that is dapsone. Next is phenazine derivative, that is clofazimine. Third, that is anti-tubercular drugs like rifampin and the ethionamide, whereas other antibiotics that can be used for the treatment of leprosy, that is ofloxacin, minocycline, and clarithromycin. Dapsone. Here you can see the drug, that is dapsone. See, the dapsone is used widely since its occurrence or invention, and it will be the major choice of drug, or the first choice of drug for the treatment of leprosy. This is what is the oldest and the most cheapest agent. Basically, it is related to sulfonamides. As we have already discussed the mechanism of action or the classes that comes under sulfonamides, they are generally inhibitors of PABA, that is para-aminobenzoic acid. Its chemical name is 4,4-diamino-diphenyl sulfone, that is DDS. So it is 4,4-diamino-diphenyl sulfone, that is dapsone, or we can call it as a DDS. Activity and mechanism. Dapsone is chemically related to the sulfonamide, and it has got the same mechanism as like sulfonamides, that is there will be an inhibition of PABA incorporation into the folic acid, and folic acid is essential for the mycobacterial growth and their cell wall synthesis. Here, folic acid is again responsible for the protein synthesis. Its antibacterial action is again antagonized by PABA itself. It is leprostatic at lower concentrations, and at relatively higher concentrations, it could arrest the growth of many other bacteria that is sensitive to sulfonamides, and there might be a development of resistance. Specificity in cases of Mycobacterium leprae, that is because of the affinity, right, for the specific Mycobacterium folate synthase, and that is the reason behind their mechanism of action, that is the affinity. Doses of dapsone that is needed for the treatment of acute infection are too toxic, and so they are not used. Here we can see the mechanism of action for sulfonamides. Para-aminobenzoic acid used to bind with pteridine to form dihydropteroic acid. With the help of dihydropterol synthetase, and it can be inhibited with the help of sulfamethoxazole and the dapsone. Whereas the synthesized dihydroteric acid will get converted into the dihydrofolic acid with the help of dihydrofolate synthetase. Now, this dihydrofolic acid will get converted into the tetrahydrofolic acid, and then the thymidine purines analogs are formed, and that can be used for the synthesis of mycobacterial DNA. So here we can have three sites. Suppose first that is sulfomethoxazole, next one the same, that is can be used by the dapsone, and the third one that is 4-trimethoprene, that comes under sulfamethoxazole with trimethoprene. Here specific dihydrofolate reductase will get inhibited, that is DHFR, dihydrofolate reductase. While coming to the kinetic parameters, here complete oral absorption can be seen with dapsone. It undergoes enterohepatic circulation and they are widely distributed in body. The major advantage, that is it will have a poor central nervous system penetration. Generally they are concentrated in skin, muscle, kidney and liver, and they are generally metabolized by acetylation process. Here the major drawback with dapsone, that is sulfur reactions. While coming to adverse drug reactions, it may produce mild hemolytic anemia, and again mild anemia might be because of dose. Next is glucose 6-phosphate dehydrogenase, that is G6PD. Deficient patients may develop severe hemolytic anemia. Gastric, in cases of gastric adverse reactions, it may produce intolerance, nausea and gastritis. While coming to central nervous system, though they are poorly soluble or poorly fragmented in CNS, it may produce woolly headedness, headache, mental symptoms just like psychosis can be observed. Here, this is the sulfur reactions or the dapsone syndrome. Here, we can see certain adverse drug reactions like peripheral neuropathy. Next is methemoglobinemia, or granulocytosis, that is again rare. It may produce hepatotoxicity, nephrotoxicity, cutaneous rashes, and the photosensitivity can be seen with dapsone. Next is the dapsone syndrome, or we used to call it as a lepra reaction. Here, these are the major signs that can be observed with dapsone. First is there will be a formation of skin rashes on skin, right, or rashes on skin, and that is maculopapillar skin rashes. There will be exfoliative dermatitis, generalized lymphadenopathy, fever even can be observed, jaundice can be seen, and generally it occurs within 6 weeks of starting therapy. And one major disadvantage that is with dapsone, that is dapsone syndrome or lepra reaction. In the cases of lepra reaction, immediately the dapsone will be discontinued, or the dapsone will be removed from the regimen. So the major thing is there will be a complete stoppage of dapsone from the regimen. Next drug, that is rifampicin. They are obtained from the Streptomyces mediterraneae. They are bactericidal in nature. Their mechanism of action, that is they generally inhibits the DNA dependent RNA polymerase. They are rapidly renders the non-infectious cases, and their minimum inhibitory concentration required, that is 0.3 microgram per ml. Component, even they are the components of the multi-drug treatment, and their dose, that is generally 600 milligram per month, will be prescribed. Coming to the uses, in cases of tuberculosis, rifampicin can be used as a first line of drug. Even it can be used in leprosy, that is next is in cases of meningococcal and H influenza meningitis. Next in cases of diphtheria, Next is brucellosis, and generally brucellosis can be observed in veterinary and used in veterinary products only. Next is in cases of leishmaniasis, even rifampicin can be used. Next drug, that is clofazimine. They are basically dye, that is phenazine dye. They are antileprotic in nature, anti-inflammatory, even it can be used as an anti-inflammatory agent. Basically, they are bacteriostatic in nature. While coming to their mechanism of action, it binds preferentially to mycobacterial DNA and it interferes with the template functioning of it. The dose would be 100 milligram per day orally. Okay. Now, what will be the overall treatment approach in the cases of leprosy? Generally, leprosy, as we know that it is a chronic granulomatous disease or infection that is caused by the Mycobacterium leprae, and it primarily affects on skin, mucous membranes, and the nerves. Here, nerves are involved because on those skin patches, it cannot carry sensation. It is more prevalent among the lowest socioeconomic strata. Many patients exploit it for begging and do not come forward for treatment. In India, the National Leprosy Control Program, that is NLCP. In India, the National Leprosy Control Program was launched in 1955 and it was changed to National Leprosy Eradication Program, that is NLEP, in 1982. With the use of multi-drug therapy, MDT, India has achieved elimination of leprosy as a public health problem, and now the prevalence rate, that is less than 1 cases per 10,000 population in December 2005. Though in some states like Bihar, West Bengal, Orissa, Chhattisgarh, Jharkhand, and UP, still they may have more than 1 cases per 10,000 cases. And this is all about anti-leprotic agent. So here the major drug, that is Dapsone, but in many cases while starting Dapsone it may produces sulfur reactions. Immediately sulfur reactions, while going with the sulfur reaction, immediately Dapsone will be removed from the regimen, and after that there will be a complete stoppage of Dapsone in the medicament list in the cases of leprosy. So this is all about leprosy. Thank you.